each of these gentlemen are hepatologists and liver transplant hepatologists, so we'll try in the next few minutes to tie together this morning's presentations and discuss some of the issues related to the evaluation and cure of patients with fatty liver disease and with advanced liver disease needing transplantation. And Dr. Runyon, you're first up at the microphone this morning, so do you have a question for the
so this is a comment. Many of my patients with NASH also drink, and Steve Harrison calls that BASH for both alcohol and non-alcoholic steatohepatitis. And one of my current fellows told me an even more fun acronym, SMASH, for simultaneous metabolic and alcoholic steatohepatitis.
All right, you know.
Can I comment on that? Actually, BASH is it's published now. We have had papers that we called it BASH, and this concept is increasing. So you can go to PubMed and bash it, and it will pop up.
Progress?
Yeah, I told Bruce we had the hotel put on Fox News for him since he's coming from New Mexico, and he had to feel comfortable. This is a question for Mason. So from a practical standpoint, the first drug's going to be approved, likely in 2020, and the Scientific Advisory Board for the FDA has to decide what is on the label. And in order to get, so the study used liver biopsy, and you just told us that that's not going to work. I agree completely. So which of the NITs should they choose?
Excellent question. So I want to comment on the label. So the FDA label will address what the trial was done. That doesn't mean the payer, that's why you're asking which NITs. The payers actually might not do what the trial showed. So the NITs, which one we should do? In my opinion, I think it should be a combination of NITs. They have plenty of data. They have thousands of patients. Their data are still emerging in terms of responders and non-responders, but they just showed this first abstract in the AASLD showing the FIB4 transient elastography. Actually, FibroSure also dropped, Alpha also dropped. I will personally use biomarkers, maybe imaging, one of them is transient elastography, and combine it with another one, whatever is available, FIB4 NAFL fibrosis score. ELF will come likely to the United States next year. The FDA approval the FDA has been also filed, but also we need more data from Intercept to show us who are predictors of responders, which combination is the best, yada, yada. And they're sitting on these data right now and trying to get it out.
So we've learned that cardiovascular disease is the biggest killer in NAFLD. And my question really is, do we have any early signals that by treating NAFLD without appropriate lifestyle changes, we reduce the risk of extrahepatic issues associated with NAFLD? For instance, as fibrosis, the degree of fibrosis, is that related to cardiovascular disease, other extrahepatic disorders?
So the answer to your question is we don't have that information yet. If we were to extrapolate from the bariatric data, certainly there's strong evidence that cardiovascular and stroke risk improve, as does NAFLD, as I showed you. Unfortunately, as I mentioned, we don't really have many agents that have been shown to reverse NAFL, but that's really an important question. And that's, as I mentioned, when I see a patient, I talk to them about, looking at your liver biopsy now, you've got, F1. I'm not concerned about liver failure or liver-related mortality, but I am concerned about, cardiovascular, so we try to enroll patients. But as I mentioned, there's actually no modeling evidence that we should be aggressively screening for NAFL because we don't have great agents now with obeticholic acid and other drugs in the pipeline that may change.
I totally agree, and this is actually a very, very important question. And I'll tell you why also. The FXRs increase LDLs across the classes. The ACC inhibitors increase triglyceride, and these patients die from cardiovascular disease. When we had the first drug showing LDL goes up, we were like, oh my God, what is this? But then now we accepted the fact that it's part of the mechanisms. FXRs all increase LDL. ACC, they do great job, at least as of today, defattening the liver based on the MRI, but the triglyceride go up. So the cardiovascular signal, all the pharmaceutical companies are aware that needs to be watched. And when I talked about non-invasive testing, one of the things that people are thinking now is start linking the liver outcome to cardiac outcome in the future. Not easy to be done. Not one of the non-invasive testings that can do that are metabolomics and proteomics. And this is some work we're doing and others doing to see if both will improve or both will worsen.
A question for Dr. Rosen. How do we try to conclude that half the people in this room, or most of the people that have urologists in this room, would not give vitamin E for the prostate cancer risk?
Right.
Furthermore, the problem is, even if you do push that data, if your patient develops prostate cancer, what's your legal risk for having advocated a treatment?
Yeah, no, I'm looking at it from the perspective of so many patients that I see, including thinking one I saw last week, who's got 3 or 4 comorbidities that will not allow her to be enrolled in a research trial. And so, vitamin E is kind of all we had right now. But those are all discussions in terms of relative risk to patients, and I try to, tell them the risks, as you mentioned, the vitamin E related risk, but also the risk of progressive liver disease. And many of these patients, as I mentioned, you're seeing them at 35, but they probably have had NAFLD since they were 10. So in terms of the medical legal risk, I think that's a really, it's a case-by-case discussion again. It's, I certainly don't use it liberally, vitamin E, but this study that was published by Nagashalasani's group is pretty compelling. And it's, again, diabetic and non-diabetic patients bridging fibrosis or cirrhosis. So in lieu of effective agents, I think it's reasonable to have a discussion with the folks.
Also, one question for Dr. Koo et al., and that is, I noted that the 50% risk of blacks receiving a liver transplant versus every other ethnic group in that 40,000 patients. Any comments, one way or the other, why?
It's impossible to speculate based on SRTR data or UNOS data set that doesn't have that degree of granularity. So
Okay.
I probably would hesitate.
Dr. Gish?
One comment from the previous person about the prostate cancer risk. That was only with synthetic vitamin E. It was not with natural vitamin E. So if you just use natural vitamin E that's available at Trader Joe's, that prostate cancer risk does not exist. And when there was a risk, it was only for more aggressive cancer. It didn't actually increase the number of cancers. It was the type of cancer that was there. So it's a non-issue if you use natural. Question for the panel.
Dr. Gish has a disclosure for Trader Joe's.
He's actually a model for Trader Joe's.
I'm at CVS, sorry, CVS. Two questions for the panel. Number one, recognizing that ALT is not a liver function test, it's a liver enzyme. How good is that to follow patients on vitamin E or some of the newer therapies? And the second part relates to this is, when are we going to get rid of the guidelines recommendation for a liver biopsy to diagnose NASH? Because in this setting where most of us practice, almost nobody's getting a liver biopsy, yet it's part of every talk, it's in the guidelines, it's not happening.
I can take a shot at this. So in terms of the NITs, getting rid of them, most payers are waiting for some guidance or guidelines coming out. So the CLDF is working on a statement paper right now, and the ASLD also, they're working on some paper, but I'm not sure where is that, to kind of start shaping this. Again, liver biopsy is not going to completely out right away. I personally don't liver biopsy. I'm a believer of NITs. Some other colleagues, they believe in liver biopsy, so it will be still an option. But for these two, like the CLDF and other societies are working on. I'm sorry, what was the first question, Dr. Gish?
So ALT is
Yeah.
being used in a lot of phase 2A studies as a marker of
yeah.
activity.
So the data on ALT is, the best data comes from gastro paper from the obeticholic acid. It was 2018 paper that they showed a drop in ALT by 12 units or so within 6 months, correlated with histology in the Flint data. So as Dr. Rosen showed earlier, that Chalasani's paper in the Red Journal was very important, saying normal ALT does not mean your patient does not have fibrosis. So at baseline, I don't yet use it as a diagnostic biomarker. However, when it's elevated and I have an intervention, such as obeticholic acid in the Flint trial, that was their gastro paper, and it's dropping down, that's helpful to us. And I assume it's going to be looked at when the obeticholic acid gets approved along with the fibrosis markers.
Nice, thank you.
Other question?
Is there an indication for screening for hepatoma and NASH without cirrhosis?
No,
Since
not
it-
yet.
Not yet.
So that's a big elephant in the room, though, isn't it? That some patients with less disease who do not have established cirrhosis and don't meet our usual criteria for screening may indeed develop HCC at lower stages of F3 fibrosis. That's sort of the scary. I think it probably scares a lot of people in this room that they're going to miss someone with HCC.
It's also interesting, I was going to say that if you look at data in patients who have hepatitis C and achieve SVR, the advanced fibrotics, those patients who go on to develop HCC, there are data suggesting that the fact that they had coexistent NAFL puts them at a higher risk, or metabolic syndrome puts them at a higher risk of developing HCC after SVR treatment. But I don't think we have parameters in terms of who we should be screening for HCC. Again, one might argue that if they have multiple components of the metabolic syndrome, they're more than likely to develop cancer, be it hepatic or extrahepatic, but I think the data just aren't there.
And it's also cost-effective analysis, right? So we're not going to go screen everyone with that. The largest study that looked at HCC on non-cirrhotic was published in CGH from a Siraj group that it was ICD code, and almost 42% actually of HCC in NASH were not non-cirrhotics. That needs to be duplicated, replicated. The mostly case reports, what we have in the literature, some people say maybe elderly men, I'm not going to choose an age, that you start screening for HCC. I do it sometimes in my patients. In once a year ultrasound, this is my thing, and because I hate to see HCC, but in most of the data may be elderly men, but as Dr. Rosen mentioned, comorbidities play a very risk factor, and he showed the obesity as well as the diabetes data. So when you have those, be a little bit more diligent.
Actually, there was another follow-up to the first paper from Dr. Al-Siraj, and actually it's a percentage drop from 37% to about 21%. And the main key factor were age, obesity, and diabetes. These were the three risk factors that should prompt concern for potential liver cancer without documented cirrhosis. But as Mazen said, these data are based on ICD code, not actually on true clinical data.
Thank you.
Dr. Littenberg.
Thank you. Should we be promoting statins now fairly liberally, regardless of cholesterol, in our patients, the ones we're seeing, with or without the 4 cups of coffee? And which statins?
Dr. DeRozio?
I think the whole world should be on a statin and aspirin is my personal opinion. And I don't have to disclose, I don't work for a statin company, but I think there's a lot of, I think that is pretty convincing that statins are remarkably safe, and these are the patients that need to be on statins.
I mean, the other advantage for using the statin the lipophilic statin are showing more and more positive result as chemoprevention for liver cancer. So that's another use. And there was older data. So I was about to ask Dr. Rosen and Mazen, Dr. Nuruddin, the LDL change with FXR agonist. There was, I think, a couple of studies or multiple studies that showed if you add a statin, you negate that effect. Do you think that's going to be part of the future?
Yeah, so we do that now in clinical trials. We add the statins. And to follow up on your comment, it's the ACC inhibitor, also the high hypertriglycerimia. We've added fenofibrate, which probably also might have effect on NASH because of the PPR effect. So yes, I think it will be used. We're going to run into another issue, which is the polypharmacy. So that's kind of like what the future look like for now. Of saying that, there are medication that, like PPR I showed you, but that was just done by Zydus, lowered actually lipid panel and lowered A1C. So the question when we go to combination therapy, if we're going to use one drug that's very effective but might have LDL and triglyceride effect, another drug that also has effect on NASH but will kind of mitigate that effect. So I think a lot of companies are following that strategy, combining these two drugs to mitigate the side effects.
What dose?
There are no data on doses. What I say, I tell them, don't be scared of statins. Start low, we'll monitor you. I don't take it over. Dr. Parkhurst.
We just published 10 milligrams of atorvastatin. It was an intercept study, but it got published in the Liver International.
That's true.
Prevented the LDL elevation state. So lowest doses of atorvastatin.
Well, my question was partially answered, but I have a compound question. How did they arrive at that dose of obeticholic acid? I know it's a different disease, but it's a lot higher than PBC. Is that because PBC is cholestatic? Because it's 10 milligrams, and now you're talking 25. And do you foresee a day that really we give people a cocktail, vitamin E, a statin, obeticholic, and Actos, because they all have different effects, and especially cardiovascular has already been demonstrated. It was that Greek study, a statin and vitamin E, the cardiovascular risk benefit was like threefold to people who didn't have NASH. So.
The obeticholic acid does came because, these trials have been in plans for years now. It came from the Flint study, which the NASCR did many years ago. I don't know what was their decision in doing it different on PBC, but the 25 milligram was positive in the Flint study. It was Lancet paper a few years ago, but started way longer, and that they continued with it. In terms of having all the medication, I will say back to the polypharmacy. We should not. I don't want to panic right away. If I have a patient, more data is evolving, and we have time with a lot of patients. So F0, F1, nowadays, we don't think those are a population that needs to be treated. There's also a role for weight loss and exercise, as Dr. Rosen showed. And we shouldn't, at the end of the day, you're putting these people on drugs. We're not going to put in everyone on drug. In my view, that if you have an F3, this is more urgent. Patient can have sample variability is biopsy. The data on progression from F3 and F4 just came out actually from the STELLAR or the Symposium trial. 1 out of 5 patients with F3 will progress to cirrhosis in 2 years. So that shows you the urgency with the F3s. Those are the population. Maybe I will try approved medications, whatever I have. But I don't recommend throwing 3, 4, 5 medications. Statins is not for fatty liver, or will be to mitigate the cardiovascular effects.
Right, but since the mortality is from cardiovascular disease, they should all be on statins.
You're right, and it should be controlled. Absolutely right.
So, and it might be more important than controlling their fibrosis, which we don't really know. So actually, I'm kind of arguing obeticholic acid is very expensive. Maybe you don't need a dose of 25, because maybe you can use 10. And if they all should be on vitamin E, natural vitamin E for Trader Joe's, and coffee, and statin, and Actos are safe and cheap, that might be the way to go before adding a very expensive drug, which really,
No,
you don't
well,
really know.
I don't want to defend anyone. It's like, one, we don't know the price of the obeticholic acid, which will be used in NASH. I'll be shocked if it comes the same price at PBC, and this is just prediction. If you want to do the 10 milligram, the trial, it actually had 10 milligram, 10, the Regenerate, which was just published in Lancet, 25, 10 and placebo. The 10 did not show statistical significance, so you have to go with the 25 because that's what the data show. But I hear your point, and that's why I said with F0, F1, let's not put people on medications. And even like we'll see what their indication come. I wonder if they will include all the F2s, although they had them on the trial, or they will just focus on the advanced fibrosis if the drug is pricey. This is all unknown. I don't have answers until we see what they will do.
Thank you.
Well, can I just follow up on that? Because the patients with NAFL, who are put on a very low energy diet, ketogenic diet, there was an abstract that showed that patients with NAFL were less likely to lose 5 to 10% of their body weight than patients who were overweight without NAFL. So are we going to be able to counsel our patients with early stage disease, just go home, exercise, diet, and you'll get better? Or is there an argument to say that they're not going to get better with those interventions and maybe we do need to put them on vitamin E or from Trader Joe's or other interventions?
So you're talking about the
Bariatric
ketogenic
surgery.
diet, bariatric surgery?
Well, just those patients are not going to respond necessarily to lifestyle changes. So are we going to promote other interventions, medical interventions or surgical bariatric surgery for those patients earlier on?
And I hear you. This is why the percentage of succeeding with weight loss is 6 to 7%, even with the obesity drugs. I mean, I was actually surprised the other day on the very small margin that they would allow them to be approved for weight loss. So unfortunately, most people fail losing weight. Still, I stick to my point that F0, F2, up to F2, we should not panic and we should do as much as we can. Even changing the diet, throwing without the weight loss, fructose away, exercising without the diet, and the type of diet as well. We worked on data with Dr. Rosen recently in USC on looking at the type of diet, which published in Hepatology. Red meat, actually almost everything came bad as meat. Red meat, chicken, but the fibers, salads, fruits were very beneficial. So yes, those that they lose weight may be changing, also like the type and exercising. One also point, and I don't want to go too much into this, the low carb diet, it's between paleo diet and ketogenic. So one factor is like the amount of fat you mentioned is very interesting in the ketogenic diet. So we actually should pay attention to these diets. Might be not good, but there's low carb. There's a cell metabolism paper showed even without weight loss, low carb diet led to change in fat in the liver within a short time. So the low carb diet still needs to be studied more. And there was paper also in pediatric people.
What do you think about?
I think also we shouldn't focus only on the liver disease. I think we should consider fatty liver as part of the metabolic syndrome. We know patients that have fatty liver, NAFL, just almost all of them have insulin resistance, even with normal glucose tolerant tests. And I think the treatment and the approach of the management of these patients should be a global look at the other components of the metabolic syndrome. I personally, in my fatty liver clinic, tell the patient, you have a fatty liver or a NAFL or NASH. I prefer to do a biopsy to confirm the diagnosis of NASH. But all these measures that they are mentioning, diet and all that, are very important, and besides the treatment of liver disease. I tell my patients, you know what, there's a treatment that it's 100% guaranteed that is going to help you, and number two, it's free. And they say, what is? Well, lifestyle modifications, I recommend Mediterranean diet, lose weight like up to 10% usually in 6 months, and exercise, tight control of the diabetes, hyperlipidemia, avoid fructose, coffee if tolerated. I usually recommend also probiotics. I don't know which ones, but since there is some evidence, I tell, okay, go to Trader Joe's, Bob Gish, and get your probiotics, start exercising, and lose weight, and that's the best you can do, and that is going to help high blood pressure, probably hyperlipidemia, obesity, etc.
So can I back up a little bit? When you see a patient, because I think most providers in this room are gastroenterologists that see patients with abnormal liver enzymes in consultation, and oftentimes all we have is say a 35-year-old man or woman with a BMI of 35 and no alcoholic risk factors, seronegative, no stigmata of chronic liver disease, and an ultrasound that shows fatty liver, and the AST and ALT are modestly elevated. The real challenge, I think, is to decide which patients is risk stratification related. Which patients are you worried about, and which patients are you less worried about, and can invoke less dramatic sort of interventions. We've talked about non-invasive markers and imaging to sort of define those patients with more advanced disease and NASH and fibrosis. But what about just seeing a patient for the first time in clinic? And maybe everyone can give a little bit their approach and how they determine the significance of the patient's presentation and how they move forward.
I usually, when I look at the patient, the more components of the metabolic syndrome, and the more likely they are going to have more advanced disease. So I take into account, I personally use the NAFLD fibrosis score. Not so complicated right now. You can online, it's very simple, use BMI, ALT, just very simple factors. Look at the NAFLD fibrosis score. And then that will prompt me to go ahead and do a liver biopsy in patients in whom I suspect progressive disease. Also, if there is a competing etiology, frequently patients have positive ANA and they have fatty liver. Is this autoimmune or not? Then that would prompt me to do a liver biopsy. And like Hugo mentioned, if they are going to have a cholecystectomy, ask the surgeon to do a needle biopsy, not a wedge biopsy. Usually they do a wedge and they send part of the capsule which looks like fibrosis. So also when they undergo bariatric surgery, just got a needle biopsy and take it and document if the patient has NASH or not. I think it's an important fibrosis information, and if the patient has fibrosis or not.
Alex, do you do the biopsy, or do you send all the patients to Mazen to use VRE?
Our IR is our best friend.
What about FibroScan?
So when I see a fatty liver patient or suspected fatty liver patient, almost all these patients will have a FibroScan in our office. And that really helps me to risk stratify these patients. I agree with Francisco about patients that have multiple metabolic risk factors are at much higher risk of having NASH. I especially worry about the older patients. So over age 60, Hispanic, male with diabetes, almost certainly will have fatty liver disease if you did a biopsy. And so if I have a younger patient that has a reassuring liver stiffness on FibroScan, those patients, I really focus on lifestyle modification. Have them come back in 6 months, try to achieve that 5 to 7% weight loss. If the liver enzymes are elevated at baseline, that's a helpful marker to look for improvement. And if the liver enzymes normalize, many of those patients, I don't pursue a biopsy. I'll just follow those patients. And if the liver enzymes rise in the future, I might consider either a repeat FibroScan or a biopsy in those situations. But those are more younger patients without diabetes and don't have multiple metabolic risk factors. But as you increase in age and as you add on the metabolic risk factors, those are the patients that typically they've tried to lose weight. By the time they're in your office, they've been on every single diet known to man. And you telling them come back in 6 months with weight loss, it's probably not going to change things at that next visit. And so many of those patients, I'm shading more towards doing those biopsies, especially if the FibroScan is showing increased stiffness.
So we kind of do the same approach. So depending on the patient age, in our clinic we have a FibroScan machine, so we kind of use it almost on every fatty liver patient. But I also use a non-invasive testing because a FibroScan is not a perfect test by itself. So I kind of agree with Mazen, do non-invasive testing, and that will give you better perspective. For patients who have discrepancy, this is when I use MRE. We have access to an MRI elastography with PDFF. That really help. The problem for me, everybody does a metabolic syndrome assessments and diet adjustment, but we're seeing a lot of patients who are lean with metabolic syndrome, and that's still a perplex in our practice, how to approach that. I mean, recent presentation at ASLD showed the metabolic factors are not as important for these patients as patients who are with a large BMI. So that also is going to be more concerning for the practitioner in the future, how to address these patients. They die of chronic kidney disease, cardiac disease, etc. But the metabolic factor were not as important for them as patients who are not clean. So that's what I usually do.
So I agree with the approach, but I think I'd be remiss not to, again, emphasize the importance of sarcopenia in these patients. And so, to Alex's point, for every patient that we have that we tell them, if I had $1 for every patient, go lose 30 pounds, I'll see you in 6 months, I wouldn't have any money. I mean, because they come back and sometimes they actually paradoxically gain weight. I don't know what's happened. But I think the discussion around sarcopenia, again, the data is pretty convincing. Patients who have decreased muscle mass, have decreased muscle strength in the setting of NAFLD have 2 to 3-fold higher chance of having advanced fibrosis. So the discussion I always have with them is, besides the weight loss, I want you to get into low impact weightlifting. There's also a lot of emerging data that peripheral adipose tissue, it appears a lot of the inflammatory signals originate from the peripheral adipose tissue and may target the liver. So I think there's a lot of emerging. Now, do we have evidence that the combination versus weight loss alone? We don't have that, obviously, but I think the data is pointing in that direction. But I agree with the approach that's been outlined here.
Yeah, and I do what was mentioned earlier. I do non-invasive testing, and as well you mentioned, all people are gonna have access to MRE. It's very accurate. Dr. Rosen showed the data already. If my transillustrography and non-invasive biomarker are still throwing me off, sometimes I do a more elastography. Unless a biopsy, unless if there's a clinical trial. We put a lot of patients in clinical trials, especially those with F3 and cirrhotics.
Just one word on pioglitazone. There's a newer form of pioglitazone coming out that doesn't have the weight loss weight gain associated with pioglitazone. So that might be another option for the future for our patients who are diabetic.
2 quick questions. I'm one of the few ID doctors here, so mine's sort of focused on, is there any signal that nucleoside therapy is synergistic with developing NASH? All our patients are on nucleoside therapy. The older ones caused steatosis, lactic acidosis, because there are therapies now where you can do nuke-sparing therapy, so if there's a signal that it's causing problems, number 1. Number 2, is there anything that the AALCID is on a macroscopic level? I mean, this is like an epidemic in a country of NASH that's coming out from a global perspective or national perspective about know your BMI or something, like know your HIV status, something to get your weight down. I haven't heard of anything, but I'll defer to you.
You just have to move to Colorado. Okay. Since I think that's the only state in the country that's not overweight. But I don't know if any really, there are some national efforts from Department of Health Services for obesity, obviously, and especially in childhood obesity, but it is the next pandemic, really, or endemic.
Let me comment on this screening because it's a passionate topic of mine. So the EASL guidelines as of today, they recommend screening for diabetics, starting with ALT and ultrasound. This has not implemented in our guidelines. So meaning, to answer your BMI question, if you see obese patient as of today, the ASLD guidelines does not recommend screening for any task force in this country. So as for diabetics, so as for dyslipidemia patient. You said in your talk that's going to change. I 100% agree that's going to change. Why it was not implemented in the ASLD guidelines? Because of the reference you mentioned, Corey's et al. Digestive disease paper that showed no cost effectiveness. There are gaps in that cost effective, very good paper, but there are gaps in it that people now are working on changes the screening. The way people are going to work on that, I think people at certain age with diabetes, not necessarily BMI, will be likely the most cost-effective people to be screened. If I want to guess the age, I'll say 40 and above with diabetes. I think that will change eventually in the future. I'm not as an expert on NUC, so there are people like more qualified than me to talk about NUC. But the HIV patients, it depends on which NUC you're talking about, the Hep C or Hep B. And Dr. Parker has quite experience in this. But in HIV patient in particular, the HIV meds has association with fatty liver, maybe with more severity. We don't know which one, we don't know why. Maybe the insulin resistant in these patients as well, maybe the lipodystrophy that you see it in some patients. So those are the data on NUC. At the same time, it's hard to study because a lot of Hep C patients are obese. So the question is, are they causing anything? Dr. Parker actually just published a paper on resolution of fibrosis after treating patients, which was a FibroScan study. So there's a signal that if you put people on NUC, you resolve Hep C, the fibrosis goes away, but they can be at the same time comorbidly obese. So it's a complicated topic, the comorbidities.
We just have time for a couple more questions. So back microphone maybe first.
Hi, just to change the direction. Alex, I'm interested in the topic that you mentioned about transplant for acute alcoholic hepatitis. Have you done a lot of that at Cedars? And generally speaking, has that affected the wait time for the rest of our patients within Southern California or California in general that are not in that category?
I mean, this is a hugely controversial topic, right? It's sort of a zero-sum game. There's only a certain number of donor livers to go around. And if you're promoting one indication that's exploding, right? And so if you look at the trends of the indications for transplant, for decades it was all about Hep C. But Hep C is no longer the most common indication for transplant. It's alcohol at the moment, and that's likely to be overtaken by fatty liver disease soon. But if you look at these trends, so as transplant for Hep C has dropped, transplant for alcohol has increased, and all the people who do transplant in this room know, which the issue is alcoholic hepatitis, we don't have effective treatments for it, right? And so patients that have high DFs over 32 that don't respond to steroids, their mortality is extremely high. Most of these patients are not going to be able to survive 6 months, of monitored abstinence to be transplant candidate. And so you have to make a decision about whether or not, you can offer transplant for these patients. So we have made the decision at Cedars, and most centers in California have also abandoned the 6-month sobriety rule. It's really not based on any evidence. We go by a case-by-case basis, and so if a patient really has very good insight, good family support, especially if it's their first decompensating event, which was really outlined nicely in the New England Journal paper, the Franco-Belgian cohort of early transplant for alcoholic hepatitis. That's really what we go by, and so it really is a case-by-case basis. But yes, this is a national trend, which is an increase in early transplant for alcoholic hepatitis.
And has that affected the waiting time for other patients?
Well, it's hard to impact it's hard to sort of comment on the impact just because there have been so many recent changes in liver allocation schemes, especially with the National Liver Review Board for HCC patients, the cap on exception points for HCC, the change to median LDAC transplant -3 points, things like that. So all these things are moving targets, but I think overall, the system where we're allocating livers based on severity of illness is always going to benefit the highest MELD patients, which typically are your alcoholic hepatitis patients.
I mean, the other point to make, even though alcoholic hepatitis is used as an indication for transplant, only a small minority of patients with alcoholic hepatitis will qualify by strict criteria for transplant. Out of 100 patient, recent paper showed, 5%, 5 to 10%. So it's a small number overall of all patients with alcoholic hepatitis.
Yeah, at UCLA, we also have a protocol for acute alcoholic hepatitis, and usually they are very selected patient, usually a young patient, 20, 25-year-old, with a MELD score of 40 that doesn't have probably life expectancy, probably more than 30 days. And we look at social situation, family support. Most of them is the first presentation of the compensation. So, and there are very few selected patients that really fulfill this criteria. I must say that this is work in progress because the study in France was a prospective study. All the patients were very controlled. They were biopsy-proven acute alcoholic hepatitis and had a great follow-up. The studies that we have in the United States, if you see relapse, for example, most of the relapse was documented by interviewing the patient. Very few of them documented PEth, for example, alcohol in blood or a blood test showing relapse. And also, I must say that also some studies even show that most of the patients did not have acute alcoholic hepatitis. A lot of the explant showed cirrhosis. So I think all this is work in progress. We'll see.
One
I think
comment
the
to
other
this?
point that was made too was that because of this, it's going to be much more important to include our addiction medicine specialist in the care of the
Exactly. Well, that's the problem. That's why the French study was so successful, because they have social medicine. The patients were followed. They have a disease. So traditionally, we say alcoholic liver disease. Okay, you 6 months sobriety, do the liver transplant. Okay, you are off the hook, and then we follow them in clinics, and then we never pay attention to the disease they have, alcoholism. So even we should transplant them and follow them up with addiction medicine. If they fell off the wagon, bring them up again, and because they have a disease that it's permanent. They need to be in rehabilitation permanently.
One point I want to make is, as a transplanting center, what's really quite helpful is if you see these patients with severe alcoholic hepatitis in your hospitals, the earlier you can refer them to our center, the better. One of the most challenging situations is when we get a really sick, high MELD 40 patient, and they're encephalopathic, and we really cannot assess the level of insight and their level of commitment to pursue transplant. And then we're stuck. And then we have that 30-year-old mother of 3 who has grade 3 encephalopathy or is intubated for every protection, and we have to make a decision. And as you've seen with the paper that I presented earlier, they have a much higher rate of problematic drinking after transplant. And so those patients, unless you can speak to them and really understand their insight, many centers would probably pass on transplanting a patient like that.
I think in the interest of time and for the coffee break, we need to adjourn from this morning's session. But if you would like to speak to any of the presenters, I welcome you to. We'll resume here at 10:50. And thank you very much. Thank you to